Hello, everybody. I'd like to welcome you to our webinar today. Webinar today is titled, What We Can Learn from Non-Small Cell Lung Cancer Using Comprehensive Genomic Profiling to Enhance Patient Care. Before we get started, though, I'd like to introduce you to our three speakers today. Myself, Dr. Snehal Thakkar, and then there's Dr. Edgardo Santos from the Florida Precision Oncology Group, and finally, Dr. Jean-Paul Delahaut from Exact Sciences. So without further ado, we want to get started, but before all that, I do have to go through a couple of disclosures. The presentation today is sponsored by Exact Sciences. Dr. Edgardo Santos is a paid speaker presenting on behalf of Exact Sciences. Any of his views or opinions during this presentation do not necessarily reflect the views or opinions of Exact Sciences. Dr. Thakkar and myself and Dr. Jean-Paul Delahaut are both employees of Exact Sciences. The educational content being presented today focuses on the Oncotype MAP pan-cancer tissue test from Exact Sciences. Information that we present today is not clinical, diagnostic, or treatment advice for any particular patient. Providers should use their clinical judgment and experience when deciding how to diagnose or treat patients. Case studies that are presented here reflect the real-life cases of a patient and/or are representative of real-life cases. These case studies are for educational purposes only and should not be interpreted as an endorsement by Exact Sciences of any individual service, product, or therapy, and individual results will vary. And if you want additional information, you can visit the oncotypeiq.com. So, a lot of you, before we get really into the meat of the discussion today, a little bit about Exact Sciences themselves. I think you guys may already know Exact Sciences from their Cologuard assay, which is their colon cancer screening test. But more recently, about approximately in the last year and a half, Exact Sciences purchased Genomic Health and brought into its family of products the Oncotype DX recurrence score, as well as the GPS assay. Additionally, more recently, they brought into the fold a company called Thrive, which uses both proteomics as well as genomics to enhance the platform of cancer screening. And even more recently than that, and that's more to the right of this slide, was the acquisitions of the TARDIS technology as well as Ashion, both of which are expanding the platform for minimal residual disease that Exact Sciences has undertaken. But today, we are here to talk about NGS tissue-based test and the Exact Sciences product, Oncotype MAP pan-cancer tissue test. Which uses both NGS as well as IHC to provide rapid tumor profiling for advanced cancer patients. So the way today's discussion is going to go is we're going to have three different avenues that we want to pursue. The first is the growing importance of genomic profiling, and that's going to be brought to you by Dr. Edgardo Santos, really talking about how NGS fits into the landscape of management of patients with advanced carcinoma. Secondly, he's going to then transition over to Dr. Jean-Paul Delahaut, who's going to discuss with us the Oncotype MAP pan-cancer tissue test and exactly what that test entails and what the report looks like. And then finally, it's going to get transitioned over to myself to have hopefully a robust discussion with Dr. Santos regarding a few non-small cell lung cancer cases and their management. So without further ado, I'd like to hand it over to Dr. Santos to take over for the next portion of today's webinar. Dr. Santos?
Thank you, Dr. Thakkar. So basically what I'm going to do is to go through the importance of how we have ended up on using next generation sequencing in oncology. So I'm going to start with the emergence of precision medicine in oncology, and this started many years ago with the Cancer Genome Atlas, the TCGA. And this was a major thing launched by the National Institute of Health and many other organizations trained to map the cancer genome. And the idea here was not only to analyze multiple tumors, as you can see there, more than 20,000 tumors were analyzed and matched with normal sample, but the key here was to identify, understand the tumor biology, and also to discover pathway that one day can take us to the development of certain therapeutic agents. So that was basically the goal of this Cancer Genome Atlas. So next generation sequencing basically is a technology in which we can analyze at the same time many genes with only a small tissue of the sample. The sample could be liquid, tissue, anything that has a specimen in which we can find the cancer. So only one single test allows us the identification of many genomic abnormalities in different tumor genes or tumor genes. And this is the difference when we do other technology. And by doing next generation sequencing, we are going to identify all this gamma of alteration, such as base pair substitution, we call that single nucleotide variant. A very famous one is KRAS that we have been studying for decades, and hopefully, at least in lung cancer, which is my expertise, we are looking forward to have 1 or 2 drugs at the end of this year approved for KRAS. But you know that that indication may go with one of those KRAS mutations. So next generation sequencing allows the identification not only of the genomic abnormality, but we can go deeper on what is the precise abnormality that we are dealing with. Also, next generation sequencing allows the insertion and deletion identification. One of the famous one is exon 18 deletion in adenocarcinoma of the lung. Copy number of alteration is very important in the case of HER2, and obviously translocation slash rearrangement, which are very important, because not because there are several pathways that has been identified, but also translocation and rearrangement are also becoming more frequently associated with mechanism of resistance to some of our first line therapy that we use in lung cancer. So when we are trying to identify mechanism of resistance, it's important that we have a good technology behind that can tell us if there is a presence of gene rearrangement. Now, these are the other ones: immunohistochemistry, FISH, PCR, next generation sequencing. They are great, they have their advantage, they have the disadvantage, but when we are dealing with cancer, in which a lot of things could happen, you need to put everything together. There is no tissue sample in a paraffin block that can handle so many of these tests for only one patient. We will exhaust the tissue sample, and we may not get an answer. So we need a technology, that next generation sequencing, the last column, in which a small amount of tumor, and Dr. Jean-Paul Delao will tell us about that, about the quantity that is needed. He will tell us how is the tiny piece that we need to analyze multiple genes, and in only one small sample, get multiple answers. So the important here is to select that therapy. And already Dr. Thakkar mentioned that in the introduction. One of the products from Exact Science is this Oncotype MAP, looking for the biomarker, the pathway that is predicted for response, so we can offer the patient the best possible therapy. Sometimes the biomarker, for example, in the KRAS, is a prediction for no response, like the presence of KRAS in colorectal cancer tell us that we will not use, for example, any EGFR inhibitor. But that's how we dissect each patient, each individual, and we can give the patient the best possible therapy. Better efficacy, less toxicity. So lung cancer has become the model, and most of the pathway today has been developing in this area, and then we have been able to identify the same biomarker in other tumors, and that's why we have some of those agnostic biomarkers. So here we have the lung cancer, the big pie. We divide those in small cell lung cancer and non-small cell lung cancer, and then all the focus has been on the non-small cell lung cancer, in which the histology is very important, because histology will determine what kind of chemotherapy or certain kind of agent can we give to the patient, just based on histology. And then from the adenocarcinoma, we have divide the pipe in smaller pieces based on the alterations that you see there, common ones based on the time that they were developed, EGFR, ALK, ROS1. And then later on, there are many, and then later on, PD-L1 with the advent of immunotherapy, PD-L1 done by immunohistochemistry, and telling us what patient may receive immunotherapy by itself or in combination with chemotherapy. And then recently, tumor mutation burden, and for that, we need a lot of genes to be analyzed. That's why we need to use next generation sequencing. Otherwise, it's impossible to deliver an answer in terms of TMB. And this is briefly how far away we went through since 1998, when HER2 started to be developed, the BCR, ABL, translocation, and then medications such as imatinib for CML back in the 1997. And then we moved slowly with EGFR, KRAS, and then more of those hot spot panels that were developed by either FISH analysis or PCR. That was the case at that time of EGFR, ALK, and others. But in 2020, we have many more because the use of next generation sequencing, and each of these technology has also improved to be a little bit more sensitive as well as more specific. So we have been able to identify other targets, and we have developed therapeutics agents against those pathways. This is just to give you an example. In a study done by Memorial Sloan Kettering, in which they complete a lot of sequencing from cancer patients, they developed this OncoKB. But the idea here was to show an evidence of what is the incidence of actionable mutation in patients that they have cancer, and they found at least close to 40% of the patient will have a mutation in which we can act, in which we can attack a specific target therapy. And this is what you hear in the news or in the scientific magazine about individualized therapy, personalized medicine, because we are targeting each individual based on their genome. Every patient is different. The thing that all fits one is already history. Every patient, in my opinion, must be tested for a genomic test. This is a graphic of the OncoKB and the clinically actionable gene that you see by tumor type, and you see on level 1 with a very strong FDA recognized biomarker plus drug approved for that specific indication, and that specific tumor is in green. You see that it's not only for lung cancer, it's lung, breast, prostate, colorectal, gastric, melanoma, multiple tumor. And this is without counting all solid tumor, because I want to mention quickly that in all solid tumor, if the patient goes to first line, because those are rare tumor, but you run MSI macrosatellite instability, or the patient have a TMB high, those patients immediately can go on second line for immunotherapy. So the next generation sequencing, the use of NGS is broadly adopted by many societies, including ASCO, which is our American Society of Clinical Oncology, and is also part of the NCCN, the National Comprehensive Cancer Network. And they have adopted certain NGS by a specific tumor type, and they also have a list of biomarkers that we should have for each of them. And here you have this specific example from the NCCN. If you see non-small cell lung cancer, what are the biomarkers that NCCN recommend? Again, there is no way that we can do them individually. Number one, if you add the cost of each of them one by one, maybe we are paying more than by that what we pay for NGS. And with the big problem of not identifying anything, because as I said before, we may exhaust the paraffin blood, or there was not enough tissue for all of them, and then you end up with QNS, and with QNS, we, the clinicians, we cannot help the patient. And then you see the biomarkers recommended by the NCCN for gastric, esophageal, pancreatic, prostate, and so on. These are those biomarkers that I call them like pan-tumor types. We call them also agnostic biomarker. MSI is one of them. Microsatellite instability. If this is high in any tumor type, you know that the patient should do well on immunotherapy at one point. Immunotherapy must be part of the equation in terms of therapy. NTRK, the neurotrophic receptor tyrosine kinase, is seen in multiple tumor types, salivary glands, some of the sarcoma. So we need to check for them, okay? So, and the other one is red, which is also seen, for example, in lung and thyroid. And in thyroid, red is very tricky because you can have, for example, a fusion protein, those gene rearrangement that you identify as a somatic changes. So you do, for example, a next generation sequencing to identify them, a feature analysis, something to look for that translocation. But if the patient has a medullary thyroid cancer, which is an hereditary disease, then the red is a red point mutation, and you need to use another technology. But this is the thing that you need to handle very quickly to see how to analyze a particular patient that you have in front of you. So I'm going to now to pass this discussion to my colleague and friend, Dr. Jean-Paul de la O, which is going to tell us the Oncotype MAP pan-cancer tissue test and exactly what is this test and what are the unique features when you use this particular test. Thank you, Jean-Paul. Go ahead.
Thank you, Dr. Santos, and thanks everyone for your attention up to now. So I'm going to talk to you today about our Oncotype MAP pan-cancer tissue test, which provides rapid, comprehensive genomic profiling to aid therapy selection in your patients with advanced metastatic, refractory, relapsed, or recurrent cancer. So let me talk to you today about our Oncotype MAP pan-cancer tissue test. So it utilizes both next-generation sequencing as well as immunohistochemistry to identify clinically relevant genomic alterations across all solid tumors. So the test performs next-generation sequencing on a panel of 257 genes to analyze single nucleotide variants, copy number variants, as well as insertions and deletions or indels. And in addition to that, 12 genes are analyzed for structural variants, including fusions. These are going to be your ALKs, your NTRKs, your MET, your ROSs. But in addition to that, the test actually offers a large IHC panel. So we offer 24 individual markers, which include PD-L1, but not all samples get all 24 markers assessed on them. So we have developed 30 plus tumor-specific panels, and these IHC panels consist of just an appropriate subset of that 24 markers that are specific to individual tumor types. So make sure you're getting the most relevant information on your report. Additionally, the test assesses tumor mutational burden as well as microsatellite instability. So while at its core, this test is an NGS test, but besides assessing genomic information, the Oncotype MAP test also examines expression of 24 proteins across these 30 tumor-specific IHC panels to provide a landscape of proteomic information for the tumor. And one of the most relevant and actionable IHC markers across all solid tumors is PD-L1, which can help guide the use of immune checkpoint inhibitors. And while it might be one of the most relevant biomarkers, it can also be one of the most confusing biomarkers to interpret. So as you can see in this table, different tumor types can have different scoring criteria as well as cutoffs. But not only that, within the same tumor type, depending on which antibody clone you use for PD-L1, those also can have different criteria, scoring criteria, as well as different cutoffs. So our expert pathology review utilizes only the appropriate scoring criteria and cutoffs based on the tumor type and antibody used, thus providing accurate and relevant and easy to interpret results on your patient's report. So microsatellite instability is assessed by this test, and it also can be used to inform checkpoint immune checkpoint inhibitor usage. And microsatellite instability really assesses for the deficiency in the mismatch repair pathway. Mismatch repair pathway is a DNA repair pathway that can recognize and correct mutations that occur during DNA replication. And deficiencies in this pathway can be assessed by looking at simple repeated DNA sequences or microsatellites. And these are prone to errors, replication errors. And by analyzing these microsatellite areas, we can assess the deficiency or proficiency of this MMR pathway. And some of you may be familiar with the PCR test, which is used to analyze just a handful of microsatellite regions. But the Oncotype MAP test uses next-generation sequencing to assess microsatellite instability across multiple microsatellite regions throughout the sequenced tumor DNA. And then the presence of specific instability signatures within these microsatellite regions that we assess can be consistent with MMR deficiency, such that if we find 6 or more regions of instability, we consider that tumor microsatellite or MSI high. And if we find fewer than 5 regions of instability, we call that MSI stable. Now, to assess MSI by NGS, we do need a minimum tumor cellularity of 20%. So any sample that is submitted that has a tumor cellularity under 20%, we will conduct MSR or MMR IHCs for MSH2, MSH6, MLH1, and PMS2, and that will be substituted to assess for microsatellite instability. So we also assess for tumor mutational burden, which really can only be assessed by next-generation sequencing, considered the amount of sequence coverage that you need to really assess, about a million base pairs of DNA. And so the Oncotype MAP test assesses TMB by measuring the total number of non-synonymous mutations per megabase of our tumor sequence genome. And of course, we use a cutoff that you're all probably very well aware of, that was developed during the Checkmate 227 trial, which tested immune checkpoint inhibitors in non-small cell lung cancer patients. And of course, that cutoff is 10. So in tumors where there are 10 or more mutations per megabase, we consider that TMB high, and less than 10 mutations per megabase are considered TMB low. So here we're kind of looking at an overall process view of a sample that arrives at a lab all the way through the process to clinical report. And every aspect of this process at Exact Sciences has been designed from the ground up with speed, accuracy, efficiency, and a very low tissue requirement in mind. And this optimization has allowed the Oncotype MAP test to be used on tumor specimens that are as small as 3 millimeters squared. It's about the size of a grain of rice, so long as that sample is comprised of at least 15% tumor cellularity. And so then we can take that tiny sample through this process with some of the optimizations and advancements shown here. We could take that sample through and generate a report in 3 to 5 business days after receipt of the sample. So all of that optimization has really changed the game of next generation sequencing, in that we can take a very, very small amount of tissue and we can turn that around to a patient report in a very short period of time, not 3 to 5 business days. But as I've outlined, the Oncotype MAP test assesses a wide variety of genomic as well as proteomic biomarkers, and that's a really critical aspect to this overall process, is the interpretation and reporting of the results from such a complex and comprehensive test. So all report content is generated from a robust evidence-based pipeline. So as I mentioned, each report's customized to the patient, which is based on the cancer site, the next generation sequencing result, the IHC result, as well as a sophisticated set of rules and logic flows. And this ensures that each report provides only the most relevant and actionable information to inform treatment decisions. And this set of rules and logic flows are developed and maintained by our evidence review board, which is a multidisciplinary team made up of PhD scientists, medical oncologists, molecular pathologists, PharmDs, as well as other subject matter experts as needed. And this evidence review team monitors multiple sources of information on a daily basis to ensure the most up-to-date information makes it onto patients' reports. And all content, as I mentioned, is reviewed and approved by the Evidence Review Board. So as evidence comes into this pipeline, it's reviewed, rules are proposed, the Evidence Review Board assesses the evidence behind those rules, and if that level of evidence is not deemed to be sufficient to be included on the report, it simply goes back into the pipeline, awaiting further evidence and subsequent review by the board. Now, our team likes to take a proactive versus a reactive approach when it comes to report content. And being proactive ensures that you and your patients receive the most up-to-date results on the report with little to no lag time between the time that the FDA approves a therapy and that information making it onto a report. For example, we know that KRAS G12C and the KRAS G12C inhibitor sotorasib is under priority review by the FDA. And awaiting that approval, we have actually developed report content for KRAS G12C to sotorasib indication, such that when that approval, assuming it does get approved, takes place, we can simply flip a switch and that information can be placed on the next report, the next patient report that contains a KRAS G12C mutation. So with this process, we've really taken great care to create a report that is a very easy to interpret report. So on the very first page, you're going to find the most relevant and high level information that you're going to need to make treatment decisions. You're going to find the key treatments based on current approvals as well as NCCN guideline recommendations. You're going to get a list of the high level interest biomarkers, the pan-cancer biomarkers, as well as clinically relevant cancer-specific biomarkers. And you're also going to see additional therapeutic options based on the genotype of your patient that have evidence behind it, but maybe that evidence doesn't rise up to NCCN guidelines or any sort of approval level. On the second page, we're going to get a little bit more detailed, a little bit more granular. You're going to see specimen details, including a tumor image, as well as the specimen specifics, tumor size, tumor cellularity. And you're also going to see those IHC results and thresholds that were utilized. You're going to find your pathogenic mutations. These mutations are going to be the same that are found on the first page, as well as other pathogenic mutations that are found, whether they may or may not impact treatment care or have any sort of prognostic information. We're also going to incorporate external proteomic findings like ER, PR, and HER2 for breast cancer patients. And then other genomic findings such as the VOSs and likely benign variants can be seen on the second page. And then it's going to be a list of therapies that may have potential increased benefit for the patient based on, again, the genomic and proteomic findings with appropriate references cited. Lastly, we're going to have clinical notes and ongoing clinical trials for the specific mutations present in your patient's tumor. These clinical notes are more of a narrative summary for each of the actionable mutations that we identified. And then there's going to be a list of clinical trials, which are based on the specific mutations that we found. And you'll find the NCT numbers there, making it easy to look up additional detail. So overall, the Oncotype MAP test, it's fast, it's comprehensive, it's actionable, and it's accurate. We all know that failure rate, longer turnaround time can impact time to treatment. In advanced cancer, there's really no time to waste, or tissue to waste for that matter. So with results available in 3 to 5 business days and a QNS reported within 2 business days, the Oncotype MAP pan-cancer tissue test can really help guide timely treatment decisions, oftentimes before the follow-up visit for your patient. And all of this while using very small sample size, including fine needle aspirations and other FFP samples. There's, again, as small as 3 millimeters squared, or the size of a grain of rice, with at least 15% tumor content. So with that, I'd like to thank you for your attention. And now I'll turn it back over to Dr. Santos and Dr. Thakkar to discuss a few case studies.
Thank you so much, John Paul. Wonderful presentation, Dr. Santos, same. So as John Paul outlined, this next phase now is going to be really us discussing a few lung cancer cases, really hoping to have a little bit of a discussion with Dr. Santos, trying to outline management of these patients and basically the real-world applications of this testing. One thing that I did want to make sure is not lost on anybody is that these are real cases, right? These are real people, real scenarios, and what we're trying to exemplify with these cases is how our decisions and how our management impact real-life scenarios. So let me start off with a case. A young female recently had relocated to a different area, had a few months, 5 to 6 month history of symptoms, virtually ignored by her. She has children and basically didn't have, quote, time to be sick. Had some cough, reflux-like symptoms, no weight loss, anything what she considered to be ominous, but eventually she ended up going to see her primary care doctor after urging by her spouse. She goes to see her primary care physician, and probably, as you might have expected, not much resolvement, but she was doing fine. But then a few weeks after that, she ends up, she's out jogging and ends up having a sudden onset of shortness of breath, way out of proportion of what she'd ever experienced before while exercising. That prompted her visit to a walk-in clinic. She goes into a walk-in clinic and ends up having a chest X-ray ordered by the APP who was the attending there. And after the APP reviewed the imaging, the patient was recommended at that point to go to the local hospital for further evaluation. At that hospital, she ended up having several tests done. Started off with the CT scan after an initial evaluation in the emergency room, and that was a CT scan of the chest, the abdomen, and pelvis. What they found was a pleural effusion. There was some nodularity also identified, some mediastinal adenopathy, thickening and enhancement of the pleura of the lung. The fluid was drained not only for diagnostic purposes, but also for therapeutic purposes with her shortness of breath. That fluid came back with findings consistent with adenocarcinoma, consistent with pulmonary origin. A subsequent bronchoscopy is done. Thoracoscopy is also performed by a surgeon. And at that point, Pleurix catheter was also placed, but the pathology from those pleural biopsies confirmed, again, adenocarcinoma of the lung with metastases to the visceral pleura. At that point, an oncology consultation is obtained. A PET CT scan is ordered. That PET CT scan demonstrates clearly hypermetabolic activity within the thoracic cavity, mainly within the thickened pleura, as well as some fluid. There was also lymph node identified, and then some individual lung lesions. Final staging was a T1B N2 M1A, or in other words, stage 4 metastatic non-small cell lung cancer. So at this point, our patient goes home, looks on the internet. Very typical of maybe a lot of patients that you guys may have. These patients, go home, and what's going to happen? And what this young woman found out, the one with the children, is that she had a 6% chance of being alive after 5 years. And the only thing that she kept talking about was who was going to put those notes in her kids' lunch boxes when she wasn't around anymore. So, needless to say, that's not where the story ends. Dr. Santos, do you have any comments about this and maybe how you might take that next step with this patient?
Yeah, thank you, Dr. Thakkar. I think that the audience pay attention to what Jean-Paul said, and also myself in the initial presentation. I will do the same thing. A patient like this, stage 4 adenocarcinoma of the lung, first things to do is try to identify if the patient has a driver mutation on around, and then also to do all the tests that Jean-Paul mentioned, the PD-L1, TMB, and all those kind of things. If the patient is, the patient have a stage 4, very well described by you. With a patient with a stage 4, most of the time, they are asymptomatic, they can wait, but this is the issue. We need a test that is fast, and we can get the answer sooner, so we can start therapy. So I will do the same thing on other NGS and wait for the result. Now, if the patient is symptomatic and needs therapy, then what I will do is to start upfront chemotherapy based on the histology, and then do not implement the use of immunotherapy whatsoever, because if the patient ends up having a driver mutation by the NGS ordered, and we want to put those TKI on board, the patient may have toxicity after being exposed to immunotherapy. So we need to keep that in mind.
Great. Very well put, Dr. Santos. I appreciate your thoughtfulness there, because you're right. I mean, we're having discussed, and this being an NGS talk, obviously that looks like that might be part of the answer here, but I think that it's always important to understand that there's a clinical scenario that goes along with that testing, and we need to keep an eye on that as well. And so appreciate your cautious approach. Moving forward, the tumor molecular profiling was undertaken, and that molecular profiling was actually reported as failed after 14 days. Before I get here to the single biomarker testing which was undertaken, Dr. Santos, maybe I can interrupt myself here and maybe ask you, how often are you experiencing a failure with the NGS test?
Yes, Thakkar, here I will join I really get a failure, so I will join that group. In the past, it was very common, but next generation sequencing has basically significantly decreased these QNS. That's number one. And Jean-Paul, he mentioned for Oncotype MAP, the amount of tumor that you need is so small that, I mean, those millimeters that you only need to run all those tests make unlikely that we will get a QNS. So the technology also has advanced. So I will readily get a failure, or I will join the 10% group or less.
Great, thank you. Well, so and I think we'll comment a little bit about this as well. You know, after getting that QNS, there was a subsequent attempt by the oncologist, the practicing oncologist who was taking care of this patient, to attempt single biomarker testing. And after 10 days, they ended up getting another result, which we will get to. But, you know, Dr. Santos, I think there's something to be said for the tenacity with this oncologist that didn't give up after that NGS failure.
Yes, I think, Dr. Thakkar, that if I have to say something about our clinician and our colleague, made a great job because he did not quit. I mean, the fact that the patient has an NGS negative, it could be explained by many factors, okay? We need to also understand that there is tumor heterogeneity, okay? And in this particular case has plenty of tissue, because if you remember, the patient had a thoracentesis which was malignant. So most likely there is a paraffin block made from that thoracentesis. And then on top of that, the patient has a lot of tissue taken during the thoracoscopy. So in this particular scenario, and considering that this patient is 39 years old, and I don't know if she was a smoker or not, but as you know, the history of smoking is irrelevant, but considering that she was an oligo smoker perhaps, or never smoked at 39 years old, there is a high likelihood that the patient may have a driver mutation. So in this case, I will give one more chance and try to either reorder another NGS, it was my case, from another biopsy that I have, or do something like my colleague did in this case. So I really congrats our colleague for doing that.
Great. I'm glad, it shouldn't be lost on us, that tenacity, because that single biomarker testing did come back with a successful result, identifying an ALK gene rearrangement. Now, again, I don't want this to be lost on anyone watching or our speakers that, you know, this was after 14 days of, and afterwards being, you know, identifying that we had a QNS, and then another 10 days for the single biomarker testing. But that being said, after 24 days, we did identify this ALK gene rearrangement, and the patient was initiated onto targeted therapy in 2016. And as you can see here, patient not only had quite a remarkable radiographic response, but this was a very durable response as well, with their most recent imaging that we had from 2020 demonstrating basically a complete response here. I think a couple of things, Dr. Santos, that you had identified that I think are very important here is not only the continuing to work towards getting that diagnosis, especially in a young female, and the idea is that a driver mutation very well may exist here. But I think also is the point you make is that we have enough tissue, and there are other reasons that you can get failure for an NGS that go even beyond the QNS. And I think it's always important that possibly reinvestigating other avenues here to try and identify some of those drivers, even in the setting of a QNS, it makes sense to maybe continue to push that envelope.
Correct, Thakkar. You are totally correct. We can't lose track, or we need to keep that in our mind.
Absolutely. Thank you. So what do we have here? We have a case. What do we learn? This diagnosis may not be in a medical emergency, but you have a 39-year-old young woman with children. It 100% is an emotional, not only journey, but emergency. Waiting can be as difficult as anything that any patient has to go through. And the disappointment with inconclusive results can lead to doubts. So how can we improve? Well, we can improve by being faster and not being lost on that. It's not only being faster on the results, but if we can't get those results, being able to communicate to you expeditiously, as Dr. Jean-Paul outlined, within 48 hours that there is that QNS result. But we also want to improve on the frequency of successful results. So what we want to do here now is I want to move on to case number 2, which is a little bit different. Case number 2, in that it's going to be a little bit more direct. We'll talk a little bit more about the therapy, but we have a 74-year-old female diagnosed with a metastatic non-small cell lung cancer. She was biopsied. I think it was an adrenal biopsy that was done. The initial workup on this particular patient was a PET CT scan, and you can see from this large pleural effusion on the right, chest wall disease, as well as likely disease within the lung tissue itself. At this point, patient undergoes NGS testing, and we have a sample report here identifying an EGFR mutation. So Dr. Santos, I'm going to interrupt myself again here, and I really want to get your take on the let's just say the report findings and how you're able to interpret this report and what you might have done.
I will do the same thing that we said before. Patients have a stage 4 adenocarcinoma of the lung, regardless of gender, smoking history. Patient deserve a genomic analysis. So very well done by our colleague. It's a next generation sequencing. They use Oncotype MAP. And then, as Jean-Paul mentioned in his lecture, on the first page, you will have the most relevant abnormalities that we can be actionable. And in this case, you find the EGFR mutation with a classic variant on exon 21, LA58R. That's a sensitive mutation. And others. So besides that, the patient has a 30% quantity of that abnormality, which is really high. So these patients have a huge possibility of different therapeutic options, going from first, second, or third generation TKI up to the clinician what the patient is he's going to use. And you can see very well described there in this snapshot from Oncotype MAP that they recommend afatinib, the comitinib, most likely there were some also lower than that because there are many EGFR TKI approved by the FDA, as you know.
Absolutely. Thank you for your interpretation and kind of helping us putting this all together with the different talks to really understand what this report identifies and how easy it is to identify that marker, what the target is, and then how we might plan a treatment plan, if you will. Moving forward, 2018 was the initial imaging study that I demonstrated. You can see in 2020, basically a complete resolvement in no longer having the effusion, no hypermetabolic activity. Patient was started on the appropriate therapy. And this is why we do this. When we have these NGS tests and we identify these abnormalities, we're able to take that next step and give somebody a targeted therapy that hopefully results in findings like this in the pre and then the post setting. So what have we learned here, right? what we've learned is that time makes a difference, right? We talked about the emotional emergency, if you will. And what we know is that after, and this is based on 5,955 samples, 6,000 samples that were accessioned during our review of our data. And we identified that the median turnaround time here was 3 business days or 5 calendar days. And what that means is that within the span of 1 week, 7 days, you will have a report in your hand identifying what findings were seen on that NGS, and you can then take that and be able to formulate a reasonable plan for your patient to put them on that journey to success. We also don't want to lose sight of the fact also that we have the 2-day QNS follow-up with the patient, with the provider, so as to not waste any time waiting for that QNS report, as we saw in the first case, waiting almost 14 days. We have also data that confirms our yield in that 3 millimeters squared or 15% cellularity content that we identify, or that we can get a successful result. But most importantly here, I think what needs to be really hammered on is that 3 to 5 business day turnaround that goes between the 50th and the 90th percentile, and the QNS being reported in anything as few as 2 business days by policy. As far as our summary and key points, personalized medicine is growing as more biomarkers and targeted agents are developed across the tumor types. NGS is included in the professional guidelines, and it's increasingly impacting how we're treating our patients. Several tumor agnostic therapies, as I think it was, both physicians, but both doctors outlined, but Dr. Santos specifically gave the indications for the tumor agnostic markers and how that can influence your patient's care and treatment plan. The Oncotype MAP pan-cancer tissue test offers a comprehensive panel for NGS and IHC testing, again, identifying the genomic as well as the proteomic actionable markers. And for patients, again, this is an emotional emergency. May not be a medical emergency, but it's an emotional emergency. So if you can do anything to reduce that time to get information back to them, what this is a value add for you and your patient. And finally, the Oncotype MAP pan-cancer tissue test can provide the information you need at the speed your patients deserve. So I'd like to thank you all for your time in following us today on our webinar. I'd like to take us to our next step, which is really to answer some questions that are out there. I'm going to be taking some of these questions and being able to direct them. Let me start off by reaching into the chat. It looks like here, Dr. Santos, I think this one will work for you. Is the Oncotype MAP test only intended for lung cancer specimens?
No, Oncotype MAP for every single tumor type. As I mentioned in my lecture, lung cancer has become a model, to develop or to discover other pathway. And some of those, like for example, RET, NTRK, BRAF, they have become agnostic biomarkers that we were able to identify in other tumor types, okay? So, no, it's for all tumor types, so that's a simple answer. As I mentioned, every patient with a stage 4 metastatic solid tumor deserves a genomic analysis. Oncotype MAP is one of those options.
Perfect. Thank you so much. Dr. Jean-Paul, I think I got one that I'd like for you to maybe tackle here. They asked specifically, what is the smallest amount of tissue I can submit for analysis for Oncotype MAP?
Right. Thanks for that question. Yeah, it is a common question. I think a lot of people are used to sending in samples, and they may be on the small side, and they get flat out rejected up front that they don't meet minimum tumor requirements. So that's again one thing that with Oncotype MAP we've really optimized to be able to utilize a very small amount of tissue, extract the most DNA possible, and get results. So if you think about the sample that you're looking at, we need, again, So 3 millimeters squared. So if you're just eyeballing a block or just looking at that, fine needle aspiration or core biopsy, you need to look for about the size of a grain of rice overall. And then about 15% of that grain of rice needs to be tumor tissue or tumor cells. So, we can accept, again, needle core biopsies, fine needle aspirations, whole biopsy, resections, as well as spun down cells. You can take pleural fluid with tumor cells in it, spin that down, pellet them, and embed those in a block. We can assess those samples as well. So as far as size, extremely small. If you're just looking at a block, you're trying to eyeball it, it's about the size of a grain of rice. If you have an H&E to look at and you can see about 15% of those cells are tumor cells, we can take that sample, accept that sample, and run it through and get you a result.
Perfect. Thank you so much, Jean-Paul. I have another question that I'm going to kind of open it up maybe to either yourself or Dr. Santos. Specifically, it's regarding the quantity or the percentage of EGFR mutation. How do we qualify that or quantify that as high versus low? Do you have any feedback on that, either one of our panelists?
So from a technical standpoint, the quantification is based on the number of NGS reads that we see across the DNA that we sequence, right? So a lot goes into that, tumor heterogeneity, how many tumor cells are there. But that percentage that you see on the report is basically the overall number of reads that we see throughout the sequencing. So it's about, think about it as, maybe that percentage of cells has that mutation. Now, of course, not all cells are going to be tumor cells. Not all cells may even have that mutation. Maybe the driver mutation, but there may be a subset of tumor cells that don't have it. So from a technical standpoint, that percentage that you see is just simply going to be the read frequency that we find that mutation at. I'll turn it over to Dr. Santos to how he maybe interprets that, or if he does interpret it from a treatment standpoint.
No, thank you, Jean-Paul, for defining that. When I saw this percentage, I mean, you're making a comparison because I've read so many different platforms, but having the 13% of the EFR and having that percentage, when this technology and other become cheaper, we can track this down also the efficacy of our therapy. So when I saw 13% from the EFR for what I have seen with Oncotype MAP and others, I think for me is a particular high expression of this mutation, as you well said, on the read of what was done in the tissue. Just basically, yeah.
Thank you. You know what, Dr. Santos, I have this one really directed to you. Specifically, Dr. Santos, what made you choose to adopt Oncotype MAP into your practice?
Well, the Oncotype MAP, the beautiful of that is the turnaround time. Yeah. I mean, to have that in 5 calendar days is really dramatic. So basically, you can have an answer that what you need for a patient that is really sick, and then to act quickly on that. So the TAT is crucial in this medical field that we are living right now.
Yeah, I think you're really hitting the nail on the head there. It's a value add, right? It's being able to not only continue to enhance the relationship between you and your patient, but if you're able to formulate that plan in an expeditious way, I mean, when we have them come back in a week, 10 days, they're doing nothing but going home and just thinking. And if we can, in any way, shape, or form, shrink that time down so when they can come back to visit us even sooner, and with those results in hand, so we can actually have a plan outlined within that calendar week, I mean, it's, to me, it's a value add. As a practicing oncologist, the sooner I can do it, and obviously in a manner that's correct, but the sooner I can get these things done and get a plan outlined to that patient, it does nothing but improve the care going forward, just to get things rolling quicker. And as you know, Dr. Santos, because that's not the end of the story, right? Because once we get those results, now we're trying to get the medications, right? So
Gotcha.
it's not like we get the EGFR mutation and then we go to the dispensary and we have all these samples ready to go. So, a lot of times we have to go through specialty pharmacies. We have to get the funding to get patients these medications. So it just allows us to initiate that second and third processes faster.
Correct, Thakkar. Dr. Thakkar, and as you mentioned, you choose a very tough cases because those tough cases that you present they had pleural effusion, and pleural effusion is very tricky. We need to move fast and identify what is the driver mutation, if there is one or not, and then move therapy quickly to avoid the repetition of thoracentesis and stuff like that as a clinician, that so many thoracentesis will put the patient in high risk for other complications, not only pneumothorax, but also lung, trap, and others. And that will be deleterious for the patient down the line. So as soon as we can make that diagnosis of a driver mutation, we can move faster, and that driver mutation, that agent that we are going to apply, will control that pleural effusion. And sometimes, as you mentioned, and on those two beautiful cases, patient will go into complete remission.
Great. And on that note, looks like we are over our time. So I'd like to thank my panelists. Thank you so much for your attention to detail and really giving great talks. And everybody who joined us online, really appreciate you taking the time out today. And please don't hesitate. If there are any questions, you can always reach out through your representative to get a hold of us for any other additional questions that do come up. Thank you again for all your time.
Thank you.
Thanks, everybody. Have a great rest of your evening.